for the method of prevention of new vessels in proliferative diabetic retinopathy. So diabetes mellitus is significantly associated with bilateral eye involvement in normotensive glaucoma, maybe due to several impaired neurovascular autoregulation processes related to diabetes. Periodic eye examinations are required for the reduction of diabetes-related visual loss, and good blood sugar control and other systemic risk factors such as hypertension and hyperlipidemia are main goals for the prevention of ocular complications of diabetes mellitus. So we have the Rotterdam study done where actually primary open-angle glaucoma, intraocular pressure, and diabetes mellitus in a general elderly population was seen, and they concluded that newly diagnosed diabetes mellitus and high levels of blood sugar are associated with elevated IOP and high tension glaucoma. So this is from the Diabetic Council, where they ask you to have a dilated examination every year and follow these steps to keep your health in track. And they do also say that diabetes can lead to a blood vessel development in the drainage angle of the eye. This was dealt by our keynote speaker in detail, and so it is actually secondary glaucoma which happens from diabetes following proliferative diabetic retinopathy. So drugs to treat glaucoma can jeopardize systemic conditions. Topical beta blockers could jeopardize cardiac and pulmonary conditions. Drugs used for systemic diseases can worsen glaucoma. You have the oral beta blockers can cause nocturnal hypertension and compromise the ocular pulse pressure. So what is perfusion pressure? Nocturnal systemic hypertension has been reported in patients being treated for systemic hypertension, and nocturnal hypertension has been suggested to be a risk factor for glaucoma progression. So let us think a little bit out of the box. Ocular perfusion pressure, difference between arterial blood flow and intraocular pressure, calculated by taking 2/3 of the mean arterial pressure minus the intraocular pressure. Diastolic perfusion pressure is that minus the IOP. Similarly, systolic perfusion pressure is that minus the intraocular pressure. So ocular perfusion pressure is decreased by increasing IOP and lowering blood pressure. Ocular perfusion pressure is directly proportional to ocular blood flow, and ocular blood flow is equal to ocular perfusion pressure divided by the vascular resistance. So all that must have been a real jumble in your head. So this was a study done. So to make it simpler, role of low ocular pulse pressure in the development and progression of open-angle glaucoma. We had the Baltimore study, which concluded that the diastolic blood pressure less than 30 millimeters of mercury, there is a greater risk for open-angle glaucoma, and the diastolic pulse pressure being less than 50 millimeters of mercury, important emerging risks for open-angle glaucoma as well. Early manifest glaucoma trials said that low systolic pulse pressure has the risk of glaucoma by 50%, and Hispanic population-based study said that the OPP less than 50 millimeters of mercury actually increases the risk of open-angle glaucoma. The Barbados study, we all know, said that low systolic pulse pressure doubled the risk of developing open-angle glaucoma, whereas low diastolic blood pressure more than tripled the relative risk of open-angle glaucoma. And this is the Egna-Newmark study, which in association with the decreased pulse pressure and increased prevalence of glaucoma said that OPP shown to be related to visual field progression. And then we have the Choi et al., who also concluded that OPP fluctuations associated with nocturnal BP dipping and worse visual field indices. So nocturnal hypertension patients who progress even after well-controlled pressures within a 24-hour blood pressure monitoring frequently have nocturnal hypertension. So low blood pressure at night coupled with high IOP in supine position compromises perfusion pressure, and it's better to use systemic blood pressure medications in the morning and avoid the nighttime dose that may cause nocturnal hypertension. Low IOP lowering drugs that lower IOP during both the diurnal and nocturnal periods without lowering the diastolic blood pressure are probably a better choice. So the inference is DPP less than 55 millimeters of mercury, important risk for open-angle glaucoma. Diastolic blood pressure more than 85 millimeters of mercury, increased risk for NTG. So surprisingly, low diastolic blood pressure significantly lowers risk of NTG, and ocular pulse pressure fluctuations related to visual field progression. As IOP increases, OPP decreases proportionally, and diurnal OPP fluctuation most consistent clinical risk factor for open-angle glaucoma severity. So prostaglandin analogs and carbonic anhydrase inhibitors increase diastolic blood pressure at all points of time. Similarly, beta blockers increase perfusion pressure from 4 a.m. till 4 p.m. but had no effect at the other times. So it's advised not to prescribe a beta blocker after sunset, and alpha agonists reduce diastolic perfusion pressure at multiple time points, primarily because of an effect on blood pressure.